Hello again, everyone. Welcome to part two of week two's lecture series. Um, this lecture is on airway assessment, end-tidal CO2 monitoring, and ABG interpretation and analysis. Um, we're going to connect the dots between airway assessment with end-tidal CO2 and ABGs, and then we'll walk through a simple systematic way to interpret ABGs. Much of which may be review for you, but maybe I'll explain it in a different way, and it hopefully it'll be a little easier. So you already know how to draw and to look at a blood gas. The goal here is to think like a transport clinician and integrate what you see at the bedside, what the capnography shows, and what the ABG confirms. By the end of this, I want you to be able to explain not just what the numbers are, but what they mean and what to do next. Why do these topics belong together? Well, airway assessment tells us what the patient looks like right now, how they're breathing, how hard they're working to breathe, and whether they can protect their own airway. The end-tidal CO2 monitoring gives us continuous breath-by-breath information about ventilation and sometimes perfusion. ABGs tell us the pH, PaCO2, the bicarb, the PaO2, SaO2, etc. at any given single moment. We're going to treat these as three parts of one story, not just three separate skills. And transport clinicians need to see a pattern, not just a monitor number or a gas result in isolation. By the end of this lecture, you should be able to do four things. First, perform and describe a structured airway and breathing assessment in the transport environment. Second, explain what ETCO2 represents, when to use it, and how to interpret basic waveforms and patterns. Third, describe the main ABG components, so pH, PaCO2, HCO3, PaO2, SaO2, etc., base excess, and what each result tells you. And finally, walk through a simple, repeatable ABG analysis sequence to identify respiratory, metabolic, and mixed acid-base symptoms. For section one, we'll focus on airway assessment. Recognizing obstruction, inadequate protection of the airway, respiratory distress, and impending respiratory failure before the monitor confirms it. And I apologize if there's some background blower noise. I'm hoping that that is not too distracting. So in terms of airway assessment, this may seem awfully basic, but I want you to get in the habit of asking three questions when you're in the field very quickly. First, is the airway patent? Can air move in and out without significant obstruction or noise? Second, is breathing adequate? What's the rate, the depth, the effort, the pattern, and is it enough to ventilate and oxygenate the patient? Third, can your patient protect their airway? Do they have enough mental status and reflexes to handle secretions and prevent aspiration and things like that? You should be answering those three questions within the first few seconds of seeing the patient in order to appropriately be able to intervene as necessary. So what to observe first? So the old look, listen, and feel from way back in the day, that still applies. So without going into all of the respiratory assessment, piece by piece, which is a 4 hour or more lecture in and of itself. Let's take a look at like quick things that you can do to successfully diagnose an airway issue based on assessment. So as far as just walking in, seeing safety, look at the patient. What can you tell? Well, their position, whether they're agitated, if they're retracting, if they have chest rise, if they're using accessory muscles, and if so, which ones? How's their posture? How's their skin color? Are they cyanotic? Are they slightly cyanotic? Are they dusky? and then your device placement, device in this case being your oxygen device. Um, and then, of course, we can auscultate and listen. So before we do that, assessing their quality of speech, noticing if they have any stridor or audible wheezing or gurgling or diminished air movement, or if there are absent breath sounds. And then, of course, their cough. Cough is something in the respiratory program that we talk a ton about. All the different types of coughs, different types of sputum production, different consistencies and colors and causes of anything foul within sputum. So a lot that you can tell just by looking and hearing. And then as far as feeling goes, air movement, chest expansion, any sub-Q air, secretions, and any effort that's required during any kind of manual ventilation. Whether you're hitting resistance, if it's tough to bag, or anything along those lines. Signs of increased work of breathing. As you know, there are many, so this is just a simple review for you. Any kind of elevated respiratory rate or tachypnea, nasal flaring, accessory muscle use, whether it's, supraclavicular or intercostal, subcostal, whatever the case. Tripod positioning for your COPD patients. Any kind of limited speech, if they have a hard time verbalizing, like if they're using short phrases or single words, if they are breathing paradoxically, so kind of a seesaw type of motion, or if they're unable to lie flat, if they're orthopnic, and anybody who's in the beginning stages of having increased work of breathing or respiratory distress, any agitation can represent hypoxemia or hypercapnia. Somnolence may represent fatigue or respiratory failure. So their level of consciousness, of course, is important. And any sign of a sudden drop in visible effort can signal exhaustion rather than improvement. We always talk about the asthmatic, and if they're audibly wheezy, and if you auscultate and you've got really loud, high pitched expiratory wheezes, well, compare that to say 4 hours down the road, same patient, and they've got kind of a faint, tight wheeze. Um, the to the layperson, they're not wheezing as much, they sound better. Well, we know that is not the case. That they're in impending respiratory failure, and their lungs are kind of clamping off, and they're getting tired, and they're at risk of buying themselves a tube. A little refresher on the different types of breathing patterns. Bradypnea, shallow breathing. So bradypnea, of course, is a slow or a low respiratory rate. Common interpretation, CNS depression, fatigue, some neuromuscular weakness. The significance for in the transport environment, of course, is a high risk for hypoventilation and a rising PaCO2 because of the low respiratory rate. Conversely, tachypnea. Often people who are tachypnic or breathing quickly are often in distress or pain. Sometimes they're hypoxemic. Metabolic acidosis, so diabetic ketoacidosis, things like that, with your Kussmaul's respirations, that can really really exacerbate, I guess, the tachypnea itself. Transport significance may be compensatory or ineffective, but either way, we need to identify what it is that's causing them to be tachypnic. Kussmaul's respirations, as in severe metabolic acidosis or diabetic ketoacidosis, um, apnea or agonal breathing, any kind of respiratory failure, respiratory arrest. Obviously, those require immediate airway and ventilatory support. And then any kind of irregular breathing pattern is something to look out for as well. Typically, irregular breathing patterns signify some sort of neurologic injury or fatigue. Airway sounds and what they suggest. So, without going through a whole lecture on breath sounds, just to recap things a little quickly for you here. It's very important to be able to distinguish between upper and lower airway um, noises. It's something that we see daily as RTs. Nurses call and patient XYZ is wheezy. Can you come give him a breathing treatment? Well, we walk in, we get to the door, and we hear him wheezing from the door. Well, if we're hearing him wheeze from the door, it's an upper airway wheeze, likely caused by inflammation, swelling, secretions, things like that. And breathing treatment in that case is not going to be effective at all. And so that's a daily battle that RTs face and fight with both nurses and practitioners. But so how do you differentiate between the two? So upper airway clues typically signify a soft tissue obstruction. So any snoring sound, think obstructive sleep apnea, folks needing CPAP, things like that, like me, even though I don't wear it. Um, any gurgling sound, any fluid-y sound, so fluid, blood, secretions, vomit, you name it. Anything that's gurgling is upper airway, likely in the throat. Any kind of stridor, so laryngeal or upper airway, narrowing, swelling, inflammation, secretion sometimes, brought upon by, viral, sometimes bacterial infections. So any audible that is stridor. And then silence is what we fear probably the most, any kind of diminished or absent breath sound, which can signify near or total obstruction of the airways or minimal airflow going in and out. Lower airway clues, so wheezing. Wheezing can be high pitch, low pitch, coarse, fine, tight. Um, Usually caused by the narrowing of the bronchial smooth muscle, often associated with bronchospasm and secretions and swelling and things of that nature. If you're hearing the wheeze without auscultating, chances are it's not a lower airway wheeze. Um, Crackles or rails, typically kind of like the Rice Krispie popping. Um, that usually signifies fluid, or if they have like a atelectatic reopening. So if their alveoli are clamped shut, so atelectatic, and then with inspiration they expand a little bit, but then on exhalation they collapse back. That can cause a crackly sound. And then any diminished breath sound, poor aeration, severe obstruction, pneumo, so air going into the pleural space, but we're not hearing it being inflated and deflated in the lung fields themselves. If they're intubated, if they have a main stem issue, if the right main stem intubated, then you're not going to hear anything on the left. Or, and we'll get into this a little more when next week when we do mechanical ventilation overview, is if the tidal volume itself is too low, then you're not going to be able to hear the air as you would if the tidal volume was adequate. Moving on to the assessment of the intubated patient, many things that we do routinely immediately upon intubating a patient. And I mean, you guys are well versed in the process of intubation and securing the tube and things like that. So again, this is going to be pretty surface level review type stuff, but confirming the tube depth. So knowing that an adult male tube depth should be somewhere in the ballpark of 21 to 23 centimeters at the teeth. Adult female 19 to 21 centimeters at the teeth, roughly as a general rule. The fixation, the visible marking at the teeth or gums, assessing chest rise, of course, confirming that you're in the right spot by noting bilateral breath sounds, confirming as well with the end-tidal CO2 detector or capnograph, and then once they're on the vent, making sure that they're synchronous with the vent. And we'll do more of that next week. Things to look for upon assessment, after the fact, especially in the back of a bus or, flight of some kind. I mean, all of the movement and the jerkiness that can really affect the tube placement. So make sure you look for tube migration, main stem intubation, cuff leak. So I'm not sure what the medic program talks or tells you about endotracheal tube cuffs and cuff leaks and things like that. But typically we put about 10 mLs of air into the cuff, and then we check it with a cufflator or some sort of cuff manometer to make sure that it is at a safe level. So safe levels we teach at -20 to -30. And that, I believe, has not changed. So, anything between 20 and 30 for a cuff pressure. I don't know if you guys use cuff pressures on the bus, but if not, it would certainly be something to look into, I would say, because managing the ET tube cuff is paramount. Look for any kinking in the tubings. Make sure they're not biting the tube. Make sure they don't have a ton of secretions that are impacting their airway at all. And then, of course, circuit disconnection. So airway assessment should be conducted after every move, every transfer, every significant change in the patient condition. But to make that part of your ongoing assessment for the time that you have the patients. And then, post intubation airway assessment is continuous, not a one-time event. But that applies, I think, less to you guys working in the field because you won't necessarily be extubating as much as you'll be intubating. Assessing for signs of impending respiratory failure, also extremely important. Things that we tend to take for granted, but should not. So mental status, ventilation, oxygenation, and the overall patient trajectory are things to look at. So in terms of mental status, are they agitated? Are they confused? Are they tired? Are they somnolent? Are they anxious? As far as ventilation goes, and this is, I mean, well, it can be for anybody, whether they're on any kind of ventilatory or oxygen support or not. But how's their effort? Is it shallow? Is it, are they hyperventilating? Are they tired? And then, of course, trending their PaCO2 and their end tidal CO2. For oxygenation, persistent hypoxemia or escalating support needs are things to watch out for, and then any kind of a rapid worsening of the patient condition despite treatment modalities and strategies that you have already employed. Let's move to end tidal CO2 and capnography. So what end tidal CO2 represents, and end tidal CO2s have really come on in the last decade or so. I recall when I was first bedside, we used them kind of sporadically, and they were kind of a pain and weren't really reliable. But in the last 10 years or so, they use end titles very frequently, and it's something that's easy to put in line and easy to monitor when it works, and it doesn't always work. But so what is end tidal CO2? So end tidal CO2 is the partial pressure or the concentration of carbon dioxide measured at the end of exhalation. End tidal, end of tidal volume, end of exhalation. It reflects the interaction of metabolism, circulation, alveolar perfusion, and ventilation all in one. In a normally perfused and ventilated system, the end tidal CO2 is usually lower than the arterial CO2 because exhaled gas is diluted by dead space. So, and this bottom point is probably my favorite here. So, end tidal CO2 is best understood as a trend and not a context dependent signal, not an isolated number. So, my experience with end tidal CO2 is kind of hit and miss. A lot of times I don't find it very, very reliable. Certain end tidal CO2 things that we have in NICU, they're even less reliable in my opinion. But um, if you have one hooked up and it's trending on the monitor, um, what you see is not going to match what your ABG shows. So if I draw gas on a patient and their PaCO2 is 46, their end tidal might read 35, 38. And so it can be a little misleading, but if you don't take it for like the actual number, but kind of like a baseline, that's where the money is. So as soon as you hook it up, and as soon as you get a good pleth, then take a look at the number, and then watch that number as it changes over time en route. So if there's a quick escalation, then you know that you are having some CO2 retention, and you can troubleshoot that way, and then vice versa. So the waveform, I'm not sure if you guys can see my cursor as I move it. I guess I'll have to play back a video to find out. Hopefully you can, but if not, know that I'm tracing the line with the cursor now. Um, so at baseline, in between breaths, your end tidal monitor should be 0. And then as you exhale, and it plateaus, That piece at the tail end of exhalation, that is where the end tidal CO2 is actually measured. This slide is more of an FYI, so that you know that there are different types of capnography. So they've got numeric value capnographs and waveform capnographs. So the numeric value ones are single and exhalation CO2 numbers. They're useful for trending mostly, but they are very limited if you actually ignore the waveform. Waveform capnography, on the other hand, displays breath by breath um, CO2 on a curve. It adds information about airflow, obstruction, ventilation quality. Um, that is preferred when available in critical care transport if you can read the waveforms themselves. And we'll get to that here in a second. Most have both. If you're connected to a monitor, then you're going to have both. The three most common uses of end-tidal CO2 in patient transport are airway confirmation, ventilation monitoring, and any kind of clinical trending. So airway confirmation, especially for anybody with an airway adjunct, especially if they're just intubated. Uh, so persistent exhaled CO2 supports tracheal placement after intubation, of course. So your purple is going to turn yellow or gold, yay for yellow. Ventilation monitoring. So once they are on, BiPAP, or if they're on a transport vent, then hooking up an end-tidal CO2 can be extremely helpful for you to track any changes. So any impending hypo or hyperventilation, especially after sedation, post-intubation, and also after you make any changes to the vent. And then, of course, clinical trending may reflect changing perfusion or response during CPR and shock states. Normal ranges for ETCO2 and the relationship between that and arterial CO2. Your typical normal end-tidal CO2 is around 35 to 45 millimeters of mercury in a stable, well-perfused adult with effective ventilation. The expected gradient, though, it's common that it's a few lower than the arterial CO2, though the gap widens when dead space rises or perfusion worsens. So that's something to keep in mind as well. So if you're trending somebody who, let's say they're intubated and they're on an end-tidal monitor, and you're used to it reading around 40, you would expect that their PaCO2 would be a little higher than 40. But if you were to get a gas and compare the two, and then a few hours later get a gas and compare the two, if the difference between the two is greater, it doesn't always mean, or it doesn't mean that it's necessarily a respiratory issue. It could be a perfusion issue. It could be a dead space issue. It could be a metabolic secondary issue. So jumping to conclusions with like, oh, they're worsening with, they're getting more hypercarbic or more hypocarbic. May or may not be due to the respiratory component of their process. How does the old end tidal work? So what makes it go up? So here we're trending, and with each breath, the CO2 on the end tidal is increasing. So any hypoventilation, any reduced minute ventilation. So minute ventilation is respiratory rate times tidal volume. So how many times you breathe a minute versus how big of a breath you take. So if you reduce any of those, then you're at risk of hypoventilating, or at least you're hypoventilating more than you were, prior. Any kind of rebreathing, so rebreathing CO2. Think about somebody who's on a non-rebreather mask, but maybe the flow isn't turned up high enough, and the reservoir bag is collapsed. Um, that patient would be at an extreme risk for rising CO2 just based on the rebreathing of it. Um, Anything that would inherently increase CO2 production in the body, like fever or seizures, things that we don't typically think about. Um, Improved perfusion that delivers more CO2 to the lungs. Um, I don't know. I'll talk with Dan to see if you need anything on ventilation and perfusion, so VQ mismatch, shunts, dead space, stuff like that. And if so, I'll provide that in a subsequent lecture. And then the last one is a good one. Anytime you're doing CPR and you get ROSC, well, that's going to make that CO2 titch up, from nothing to whatever it is at the next breath. Conversely, what makes end-tidal CO2 fall? Well, anything that increases a patient's ventilation, in a nutshell, and there are other reasons too. But so hyperventilation, so increased respiratory rate, excessive minute ventilation, so taking deeper breaths or breathing faster will make your pleth shrink, I guess, or fall. Any reduced perfusion to ventilated alveoli, as in shock or cardiac arrest, that will also make your end-tidal fall. Pulmonary embolic disease, so pulmonary embolism, increased dead space, sudden disconnection from the circuit, apnea, loss of airway integrity, and a severe reduction in metabolism in some settings, but that's less likely. Waveform interpretation is very important. There are a handful of basic patterns, and if you can get to where you can identify any of these, then you'll be a huge advocate for your patients. So the next slide has it in more detail, but this is more a condensed table for you. But as far as the waveform goes, if it's normal and square, normally square, and there's consistent exhalation sampling, typically that's just your stable intubated patient. If there's a shark fin upstroke, that's indicative of an obstructive something that is obstructing on the exhalation side of the breath cycle. And examples are bronchospasm, airflow obstruction. If the waveform is low and flat, then that typically indicates that there is low CO2 delivery or low sampling. It's just not getting adequate perfusion to be able to read properly. Signs of that would be somebody in shock, somebody who's hyperventilating, if there's a large leak in the circuit, and things like that. If there's a sudden loss of a waveform, so there's no exhaled CO2 reaching the sensor, if it goes from your square waves to flat, that usually indicates they're either disconnected or they're extubated or they are apneic. And then if there's an elevated baseline, so remember the base, my hands are, the base of that waveform should be 0, right? If it's not, if it went from 0 to here, and then your waveform, that indicates that there is CO2 at and that or CO2 when there shouldn't be. So they're rebreathing CO2. Typically, that's a circuit or a valve, or again, if they're on a non-rebreather or even a bag valve mask. If there's not enough flow going to the device to inflate the bag and keep it inflated, then they're at risk of rebreathing CO2. And if there's an end tidal hooked up to it, you'll see that baseline elevate a little bit as the CO2 rises. I won't spend too much time on this, but it's worth looking at and maybe even printing out. Maybe I'll see if I can give you a printout of this, but um, better to put pictures with words. So normal waveform, as you can see, nice and square, nice and level, returns down to 0, and then your end tidal is right there at the D marking. Bronchospasm, anything that's shark fin like that, that's usually on expiration. So sloped or prolonged phase, classic asthma, COPD exacerbation. Think airflow obstruction when they have an end tidal that's got the shark fin. So think bronchodilator, suction, things like that. Here's an example of increasing end tidal CO2. So they're beginning to hypoventilate. And then conversely, decreasing CO2. So any form of hyperventilation. Here is a great picture of rebreathing CO2. So here we're at the baseline. We've got a nice perfect little square waveform, and then see, it trickles up a little bit, and then it rises, and then we're retaining a little more CO2, and rises, and even more. So with each breath, this person is rebreathing their CO2. So if you see that on the monitor trend, that's something to troubleshoot like right away. The Curer cleft, dip in the plateau that appears when a patient begins to breathe over the vent. So this you may see. So this is if they're kind of asynchronous or dysynchronous with the vent, and they're pulling a breath like during a vent breath cycle. Then you'll see that little dip, and that dip just indicates that they are initiating or triggering the vent when it's not ideal for them to. Cardiac arrest, flat, baseline, and then ROSC. I can't see because my face is in the middle of this one, but it should go flat and then boop, back up to a normal one. Entitled CO2 during procedural sedation and RSI. So the end tidal often changes before oxygen saturation falls during hypoventilation or airway obstruction. So that is important to kind of trend as well. So if you have the option to put an end tidal on during your procedural sedation and rapid sequence intubation, then do it because it can help to identify apnea, partial obstructions, inadequate respiratory efforts early, um, sometimes even before you can visually see it with the patient. After intubation, persistent capnography supports tracheal placement and ongoing airway integrity. And then during transport, continuous capnography helps detect dislodgement, disconnection, changing ventilation needs, all sorts of monitoring parameters. There are several limitations to using end tidal CO2 monitoring. It doesn't directly measure arterial oxygenation, of course. And here you see in the picture that I stole here, it's reading 5, and you see the waveform is pretty shoddy, kind of like a shark fin, but it's just not just not reliable. And these things are awfully finicky. Um, so the end title might underestimate the actual PaCO2 in high dead space states and in severe lung disease. So if you've got a bad COPDer, then if you have them on an end title monitor, it may or may not even be close to what their actual PaO2 is if they're a retainer. Um, so the trending are powerful, but blood gases are definitely definitely still the go-to when you have any question on the patient's acid base status or where you need to know their actual arterial CO2. Section 3, we get ABGs, and this could be a whole course, but we're gonna streamline some things and get through it in a few minutes. So largely a review, but maybe we teach in ways that might be helpful to you. Why do ABGs matter? Well, for a lot of different things. So ventilation, oxygenation, acid-base status, etc., etc. The PaCO2, or the partial pressure of arterial carbon dioxide, reflects the arterial CO2 burden and helps to evaluate alveolar ventilation. Um, there is I don't know if you guys do anion gap and base excess and all that stuff in medic school, but um, I could talk about that down the road if you want. But minute ventilation, as I said a little bit ago, is tidal volume times frequency. Alveolar ventilation um, is removing the dead space component in the airway. So that's tidal volume minus dead space, anatomical dead space, times the frequency. Oxygenation, so your PaO2, so your partial pressure of arterial oxygen, helps to define the oxygenation status in the context of FiO2 and the clinical disease. That's very important, and I'll get into that in a second. And then the acid-base status, of course, so your pH compared with your bicarb and any kind of related values that help to explain, whether or not you've got a respiratory or a metabolic issue at hand. A quick review of ABG terminology. So your pH determines the overall acidemia or alkalemia, or if they're acidotic or alkalotic, acidic, alkalemic, all kinds of different ways to say the same exact thing. Your PaCO2, that's your respiratory acid component, and that answers the question, is ventilation removing CO2 properly or adequately? The bicarb, so HCO3 negative, that is your metabolic component, that's your renal buffer component, and that helps to be able to distinguish whether you have a primary or a secondary respiratory or metabolic disturbance. And it also is the main catalyst for buffering, for compensation. So when you have a blood gas, if they're uncompensated, partially compensated, fully compensated, the bicarb is typically, especially in a respiratory issue, it's the buffer that's moving up or down to try to pull the pH back to a normal value. Your PaO2, that's your arterial oxygen tension, so how well oxygen is moving into the arterial blood. Your SaO2, that's the hemoglobin saturation, how much of the actual hemoglobin is carrying oxygen. And then base excess or deficit, that's a metabolic contribution estimate. Um, and we'll go less into that. Normal values for ABGs, 7.35 to 7.45 for your pH, 35 to 45 millimeters of mercury for your PaCO2, bicarb, 22 to 26 roughly milliequivalents per liter, and then your PaO2 varies with the FiO2, but usually a normal healthy adult will have a PaO2 somewhere between 80 and 100 on room air. The SaO2, usually 95 to 100%, so it's a percent in healthy adults on room air, and your base excess is usually between 2 and -2. When should you draw a blood gas in transport? Well, if you're drawing a radial gas with a radial stick in the back of an ambulance, that's going to be a little tough if you're moving. But when in doubt, I mean, you got to get what you got to get. So if you have any kind of unclear ventilation status, when the end tidal maybe is unreliable, or the gradient between the PaCO2 and the end tidal is kind of wonky, like if you're looking at a patient and they look like they are going down, and they're hypoventilating, shallow breathing, um, and their end tidal is reading 25 and not moving, chances are that end tidal is not reading accurately and is not an accurate representation of their actual PaCO2. Anytime there's a severe acid-base derangement, so difference between the two, including diabetic ketoacidosis, so DKA, sepsis, renal failure, any kind of shock or mixed shock state, usually good to have a blood gas to at least get a baseline value. If you've got a patient who's got persistent or complex hypoxemia despite oxygen or vent support, yep, absolutely. If you are making any kind of ventilator changes, so vent titration in unstable or difficult to interpret respiratory failure, basically, we're of the practice that we typically get a blood gas to determine whether or not a patient needs to be intubated. Not always, but doesn't hurt. And then once we put them on a vent and the initial settings, then 30 to 60 minutes later we'll get a blood gas, and then we'll make changes to the vent based on that blood gas. And then after we make a change, we wait an hour or so and then get another gas to make sure that the change that we made worked or didn't work. So don't be afraid of or strangers to drawing blood gases. There are all kinds of limits and cautions and hazards and things associated with ABGs. One thing that people don't always remember or consider is that a blood gas sample that's drawn is literally an intermittent snapshot, not a continuous monitoring tool. So while values don't change that quickly, they can over time depending. Depending mainly on the type of intervention that's actually going on. So if a patient gets sedation, or if the clinicians make an event change, or if there's a significant quick regression of the disease process, whatever they're on or whatever they have, that can change the values pretty quickly. Sample quality, timing, documentation of FiO2, specifically temperature, things like that. Those matter. And if they're not put in the analyzer properly, then that can impact the actual readout. And then a normal pH may be misleading and hide a mix disorder if both the PaCO2 and the bicarb are abnormal in offsetting directions. ABG analysis, this should be reviewed. Step one for ABG interpretation is looking at the pH. So determine whether or not the pH is normal, and if it's not, if it's low or high. So 735 to 745 for a normal range. Anything under 735 suggests an overall acid burden. And then anything over 745 suggests an overall alkalemic state or alkaline. A near normal pH does not exclude a mixed disorder when both the CO2 and the bicarb are abnormal. Just FYI, caution for that. But step one is looking at the pH, and then step two is determining whether that pH imbalance is primarily caused by a respiratory or a metabolic process. So for respiratory issues, the pH and PaCO2 are inversely proportional. So if somebody has a respiratory acidosis, so here primary respiratory acidosis, their pH will be low and their PaCO2 will be high. A primary metabolic acidosis, so pH and bicarb are directly proportional. So if it's a metabolic issue, a metabolic acidosis, then your pH is going to drop and your bicarb is going to drop alongside. Conversely, if there is a respiratory alkalosis, then your pH rises and your CO2 falls. And then a primary metabolic alkalosis is when both the pH and the bicarb are abnormally high. Step three, once you've determined if you have an acidotic or an alkalotic pH and whether or not it's respiratory or metabolically driven, you check for compensation. So you look at the other value. Respiratory disorders are always compensated by renal bicarb changes over time. So if your pH is low, so 730, and your CO2 is high, say 55, and their bicarb is elevated as well, then the patient is compensating, or they are partially compensated respiratory acidosis, and that's a slow buildup over time. Metabolic disorders, on the other hand, are compensated mainly by changes in ventilation and PaCO2. So those with metabolic acidosis or metabolic alkalosis, they change their breathing pattern, rate, depth, etc., to help compensate for the metabolic disturbance. Compensation moves the pH toward normal, but doesn't usually overcorrect it beyond normal. And if the expected compensation is absent or excessive, then suspect a mixed disorder. In terms of a respiratory acidosis, where the pH is low and the PaCO2 is high, the bicarb can be either normal or high in most cases. If it's normal, then it's an acute situation, so uncompensated respiratory acidosis, that's an acute respiratory failure. If it is If the bicarb is elevated, then that suggests some sort of compensation. So usually that's some form of underlying lung disease. Common causes of respiratory acidosis: hypoventilation, opioid overdoses are a big one. Neuromuscular weakness is a big one. Severe airway obstruction can cause it. Fatigue can cause it. And if you're underventilating them on the ventilator, that will cause it as well. Respiratory alkalosis, so somebody with a high pH and a low PaCO2, usually somebody who is hyperventilating or suggesting something like that. The bicarb itself may fall over time if the compensation develops. That is less common than a bicarb compensating in a respiratory acidosis. But common causes for respiratory alkalosis: hyperventilating, and that can be from any number of things. So pain, anxiety, hypoxemia is a big one, sepsis, CNS stimulation, or an early salicylate effect. Switching gears to the metabolic side, so metabolic acidosis, that's when the pH is low and the bicarb is low, and the PaCO2 is either normal or low. The the CO2 will fall if ventilation is intact as the patient tries to compensate for the metabolic acidosis component. So common causes for metabolic acidosis: lactic acidosis is a big one, ketoacidosis in diabetics, renal failure is a big one, exposure to toxins, and then if you've got diarrhea, severe shock, those are all leading indicators for or causes for metabolic acidosis. On the flip side, metabolic alkalosis is when the pH and the bicarb are both high, and then the CO2 may rise with it if there's some compensatory mechanism, if the respiratory drive permits. Common causes for metabolic alkalosis: vomiting is a huge one, gastric suction, diuretics, loss of chloride, post-hypercapnic states. Um, Usually that is due to a fluid loss, loss of the positive hydrogen ions in the pH, usually caused by things like vomiting. So your steps in a nutshell: check the pH, identify the primary process, respiratory versus metabolic, assess the compensation, whether or not the CO2 in the event of a metabolic disturbance, or the bicarb in the event of a respiratory disturbance, um, whether they are abnormal or not, compensating or not. Make sure you look for mismatch or a mixed disorder. Those are more common than you think, and they don't rule anything out per se, but they can help to identify if there's an additional issue, like if you're treating for a respiratory acidosis, but there's a metabolic component as well. It's good to be able to identify that on a blood gas so that you can start treating the metabolic issue in addition to the ventilatory one. And then interpret your oxygenation in context. I'll get more into oxygenation in the next lecture, but let's take a look at this one. So first example: acute respiratory acidosis. So acute or uncompensated. So we've got respiratory acidosis. So pH low, 724, CO2 high, 60, bicarb 25, normal, so uncompensated or acute, and then your PaO2 of 68. So normal PaO2 values for a non-COPD patient are 80 to 100. Normal PaO2 values for COPD patients are 60 to 80. 60 a PO2 of 60 equates roughly to a SPO2 or a O2 sat of 90. And so that's a good way to kind of gauge maybe you've got an unreliable pulse ox or you have a hard time picking up the pulse ox. The PaO2 can help to identify where they're at as far as saturation goes. So interpretation would be acidemia with elevated PaCO2 and near normal bicarb. It's normal. Suggests acute primary respiratory acidosis with mild hypoxemia. Here's a fairly common example as well of a partially compensated metabolic acidosis. So see, we've got a low pH, 728, a low bicarb, 11, and then a low PaCO2, 24. So in terms of analyzing, take a look at the pH for step one. So it's low, so we're acidotic. Okay, where's the CO2? If it was high or elevated, then we would suspect a respiratory acidosis. Since it's not, well, 24, I don't know. Where do we go from here? Well, go to the bicarb. If the bicarb is low, like the pH, because bicarb and pH are directly proportional, then that suggests a primary metabolic component. So we've got a metabolic acidosis. And then is it compensated, partially compensated, or uncompensated? Well, since the CO2 is low and the pH is not normal, it is partially compensated. So acidemia with low bicarb indicates primary metabolic acidosis. The low CO2 suggests a respiratory compensation. The third example is an interesting one, and again, if you guys need if this is not review for you guys, and I apologize, I don't know where you guys are at in the whole process, but if this is meant to be a review, and I'm highlighting some unusual cases, I guess. If you need ABG practice at all, please let me know. I have a ton of ABG worksheets that you can use if you need to go back to the basics and have me draw it out on a whiteboard. I'm more than happy to do that as well. I prefer to do that over stare at a screen and read off a slide. But yeah, any case, let me know. And I guess now that we're an hour into this, good grief, it was supposed to be 80 minutes, by the way. So you can thank Dan for that. But anywho, all right. So let's take a look at this one. So we've got a pH of 7.40, so that is perfectly normal. So if you stop there and you assume that they're fine because their pH is normal, well, you're missing two big pictures. So with the pH of 7.4, you would expect the PaCO2 to be either 40 or greater. Greater if they're, if they've got some sort of CO2 retention, or somewhere in the normal range. If it's low, then that's indicative of not so much a respiratory issue, but a primary metabolic issue with some respiratory compensation. So take a look at the bicarb. So the bicarb, if it was not a metabolic issue, it would be normal because the pH is normal. But because it is low, that means that, what does that mean? It means there's a primary metabolic acidosis component, and the patient is trying to compensate with their breathing. And if their CO2 is low, then you can assume that they're chugging to try to compensate. So we've got a near normal pH, or normal in this case, with both low PaCO2 and bicarb. So that is a mixed disturbance or a strong compensation. Context in this case is essential. So if you get a whacked out gas like this, look at your patient. How is the patient presenting? Are they presenting more with some severe hyperventilation? In which case you would worry about their pH and the bicarb and how that's impacting it. Or do they have a history that suggests some sort of metabolic acidosis, in which case they are trying to um, correct that by changing their breathing pattern to help raise the pH. I've given this to students for years, and I put it in the PowerPoint here, and I will upload it into Canvas as well, so you can use it for a cheat sheet. Basically, it's everything I just talked about laid out into a nice, or I think nice, colorful, color coded um, one pager for you. So on top here, we've got the definition, we've got normal values. Um, Relationship between pH and bicarb and carbon dioxide. Um, the arrows for those who like to memorize up and down. I do not. I don't recommend it, but to each their own. And then a comprehensive list of all acid-base disturbances, what they look like in terms of the three primary values, and then just one example of each, just for your for grins and giggles, and then an outline of the steps for interpreting them. So to put all these things together at the bedside, whether it's at a hospital that you're picking the patient up at, or if it's their house, or if it's in the back of the bus or helicopter, whatever the case may be. If you look at these three components, when you have somebody who has an airway or breathing difficulty, then locking them all together is something that will greatly benefit you in determining the overall picture, the big picture, and what's going on with the patient. So assessment, airway assessment. What do you see? What do you hear? What do you feel? Um, Go with your gut. Keep it simple. End tidal monitoring, if you have that available. Um, what the initial value is, how it trends over time, how the waveform looks, whether there are any waveform disturbances that suggest that you need to intervene in a different way. Um, and then, of course, ABGs, and especially when we get into intubation, mechanical ventilation, making changes based on blood gases. Those are paramount for folks who are in respiratory distress. Key takeaways, and I hate to just read it, but um, I'll just read it. Airway assessment begins with rapid bedside recognition of patency, airway patency, adequacy of breathing, and the ability to protect the airway. End-tidal CO2 monitoring provides continuous information about ventilation and may reflect circulation and dead space effects based on the waveform. ABGs define the acid-base status, arterial CO2, PO2, oxygenation much more directly than non-invasive monitoring. ABG interpretation becomes manageable when approached systematically, and being able to look at a blood gas and not only know what it is but know what to do about it is supremely important in the transport environment. But the best transport decisions come from integrating all of these things and looking at the big picture with the patient. Next, we'll go into oxygenation, ventilation, and some mechanical ventilation, but that'll be more next week. And I appreciate you sticking with me until the end. I know it could be a slog, and you're off, doing other things and multitasking, and I'm just kind of rambling in the background. But I appreciate it.